Hi, this is Brian Kim. I'm going to share with you case number 220 in the Best Way to Do Cataract Surgery series. This is a medium-sized pupil, 2+ dense lens, and you're going to see double chop, cross chop mechanical fracturing, and systematic careful lens disassembly in this case. So the main concepts are to use the two instruments, your chopper and the phaco tip, to apply opposing forces around the endonucleus, and you can fracture the lens purely under irrigation fluid without using ultrasonic energy or vacuum. So this is the patient's eye. You can see this is the left eye. There's a little bit of Bell's reflex. I'm using the cotton tip to steady and center the eye. And then this is the corneal marker, which will help me to center and size the rhexis. This patient has a little bit of trouble controlling the eye. I'm trying to turn the eye down. And I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. Again, this is a left eye. The patient clearly has a Bell's reflex, and I'm using the Orlock technique to turn the cannula sideways, and then I'm pulling the eye down. So this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then when I'm ready to enter, you can see I turn the cannula sideways, which allows me to provide some counterforce, and then I was able to enter. I go ahead and re-engage the Orlock technique with the cannula, and this is the capsular rhexis technique using the microforceps. I puncture the center, pull down towards me, grabbing the right side of the tear with the microforceps, going around circumferentially. Because these are very thin forceps, the OVD egress is minimal, and so I have very good control of the rhexis, very little radialization forces as I'm doing the rhexis. The main thing here is I'm using the cannula to create that Orlock so I can turn the eye down. Otherwise, the patient's turning the eye up, which again is to the right of the screen. And so this gave me excellent control using the Orlock to perform my capsular rhexis. And this is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge, contra-incisionally, slide it under the rhexis edge, point the tip down, get a nice wave, lift the lens up, decompressing the bag, pushing the lens back into the bag, sweeping under the rhexis edge and pushing BSS on the left side and then the right side, and the lens begins to spin. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. Again, the patient was at an advantage because they're having this Bell's reflex and moving it whatever they want to. But now that I have two instruments, I have the control. So I slide the chopper under the rhexis edge contra-incisionally, turn the phaco tip vertically sub-incisionally, get around the lens, and I'm able to fracture the lens with horizontal forces. That is double chop. I slide the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip and fracturing the lens in half, and that is the cross chop. I use some vacuum to lift that first quadrant up, getting the chopper around it, fracturing it in half with another cross chop maneuver, and then emulsifying the lens pieces. Loosening that second quadrant up, sliding the chopper around the lens in another cross chop maneuver, fracturing it against the phaco tip, and then grabbing the pieces with some vacuum, crushing it into smaller and smaller pieces, and then emulsifying the lens pieces. So again, that's the whole point of why I'm showing all my fluidics on that right side and the left side on the screen. You see that I turn on and off, on and off. And again, if you pay close attention, I only have the ultrasonic energy and vacuum on when I'm ready to emulsify. So again, you see I turned that second heminucleus in front of me. There is nothing on except infusion when I fracture that lens in half. I slide the chopper around the third quadrant, doing the same thing. Again, there's nothing on except infusion. I fracture that third quadrant in half. Only when I'm ready to emulsify the lens pieces, you see I start crushing the lens into smaller pieces, but then I activate the ultrasonic energy and vacuum, pulsing it and removing the lens pieces. Using some vacuum to grab that fragment, crushing the lens into smaller and smaller pieces, and then emulsifying the lens piece. So again, turning it only on when I'm ready to remove the pieces. So again, all the pieces are out now. I remove the epinucleus. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the eye handpiece, start subincisionally peeling from anterior to posterior. By removing the cortex from anterior to posterior, you'll get a cleaner removal of the cortex with less remnants that are left behind. The polymer tip allows me to polish the posterior capsule as well. This is very safe, and you can use your foot pedal control to modulate the amount of aspiration and vacuum you're using. Alternatively, you can switch to polish mode. So I go ahead and remove the cortex on the left side, and then now switch to polish mode. Again, a nice clean bag, mainly because I was able to pull the remnants, grabbing the anterior cortex and peeling it from front to back. I'm pulsing BSS into the subincisional capsule fornix, which was clean, turning off infusion, and then I'm pushing cohesive viscoelastic to fill the bag. And again, this is a medium-sized pupil. The rexus and the pupil are about the same size. Trying to find my incision. There it is. Couldn't find it. And then again, I'm not going to be too aggressive. I try to push cohesive viscoelastic between the capsule and the iris whenever I can, but sometimes it's unavoidable. You can have the capsule close to the iris here, and so if you're too aggressive with the sweeping, you can actually cause some pigment dispersion of the iris. Once I do the sweeping, I place the single piece acrylic lens into the capsular bag. I turn the eye away from me. It allows me to see the capsule edge contra-incisionally, so I can make sure that the lens comes out and goes underneath the rexus edge. I go in with irrigation off, activate irrigation, disengage the haptics off the optic, get underneath the lens, tilting it and rotating it 90 degrees, removing all the viscoelastic from within the bag, repositing the optic back down. I can tell as I'm doing this that both haptics are in the bag. I go ahead and polish under the rexus edge. There's some fine wispy material on the capsule, so I'm going in polish mode and removing the rest of that off. Remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a 2+ dense lens, medium-sized pupil, but you saw very well executed double chop, cross chop mechanical fracturing techniques. Remember, 2+ dense lenses are actually pretty nice. They're not so brittle like a soft lens where things just fall apart. They're not super dense where you're using a lot of CDE and causing corneal edema. So really, a lot of people would look at a 2+ dense lens as kind of like the ideal lens for a wide range of techniques: divide and conquer, stop and chop, horizontal chop, vertical chop. Really the easiest lenses to remove. But you can see with this technique how efficient I am at fracturing the lens in half, and how I'm not using vacuum, I'm not using energy, I'm not using any of those things. All I'm doing is positioning my chopper and phaco tip around the endonucleus and fracturing it in half. And that takes a lot of practice because, again, we weren't taught to do it that way. But as I've done this now over thousands of patients, I'm very confident and comfortable in doing this maneuver. And again, you're not causing any capsule stress. Why? Because remember, the peripheral lens is soft. And so as you're manipulating the instruments within the bag, cutting through, almost like cutting through Jello, you're cutting through the peripheral lens material, which is soft. And I'm able to get each instrument kind of down and around the endonucleus, and that's why I'm able to crush it with sideways forces, fracture the lens very efficiently, and then cross chop so nice because I can cross chop from a variety of angles, breaking the lens into smaller and smaller pieces. So again, you saw this 2+ dense lens, but the CDE was very low. This patient's going to have a nice crystal clear cornea post-op day 1 with good vision. And so this is why I advocate performing double chop, cross chop, and leveraging mechanical fracturing, going after lens pieces using your instruments rather than going after pieces with high vacuum into the capsular bag. I think that's poor technique. Don't go after pieces with high vacuum. Pull pieces up with the chopper, hook the lens pieces up, bring it into the central safe zone, and you'll be able to minimize your risk for complications and be more efficient with your lens disassembly technique. So I hope this was helpful to you, and I thank you for your attention.